obstetric scan, a systematic approach. Obstetric scan we are doing in second trimester, in which we have to go for 7 steps to follow. 3 is the anatomical plane and 10 is the outer limit. 3 in anatomical plane we have to see for the structure to be identified in each part of fetus, and 10 is the outermost limit for any measurement. Likewise, more than 10 mm lateral ventricle at the Sylvian sulcus, we can call it is a ventriculomegaly. Ureter or pilectasis or renal pelvis dilated more than 10 mm, then we can call it is a hydronephrosis or sometimes hydroureter. In 7 basic steps. First step is history. By definition, history is study of past in light of present to have good future. Patient came to us with something complaining in past, narrating in present, and we are doing very good or best for our patient by taking the history. In Bible, it says, give thou ears. Listen them carefully. 90% of all the problems is coming from the history, and we are taking history day in and day out from our first MBBS presentation. Then we have to go for survey. Just like eagle, we have to survey the whole abdomen. Then specific measurement, biparietal diameter, head circumference, abdominal circumference, femur length. These are the main biometry. Then for particular organ, we have to go for targeted scan. Just like in the skull, which are the 3 things we have to see. In abdominal section, then in limbs, everywhere we have to follow the rule of 3. Then fetal environment is comprising of placenta and liquor, and we have to see for fetal activity, and ultimately we have to give them the very good TIFA report. Why we want to take the history? Because at the first juncture, we have to give them the exact EDD. For exact EDD, we have to ask for the exact LMP, or we are not able to define exact LMP, we have to calculate the approximate gestational age by ultrasound and LMP both. At this juncture, we have to classify this patient as a high risk or low risk. And this particular situation, when patient comes to you, you have to identify the risk factor. Likewise, menstrual history, obstetric history, medical history, and family history. These are the 4 important history of the patient in history taking examination. For example, a 22-year lady comes to you with first child has got Down syndrome. Usually we are watching Down syndrome after the age of 35 in elderly patient. But if this lady has got first child with trisomy 21 or Down syndrome at the age of 22, in second pregnancy, you have to remain cautious, you have to do anti-scan, you have to go for knuckle translucency, you have to see for tricuspid regurgitation, you have to see for pilectasis, you have to see for saddle gap tooth. These all are the soft markers came in ultrasound. But you have to combine this with biochemical marker like NIPT that you can do in first trimester, and in second trimester you have to go for quadruple marker or triple marker, and if she comes in high priority, then you have to go for amniocentesis or photosynthesis, because we can't afford this lady to have a second trisomy 21 child. Likewise, 26-year primary with first cutaneous Duchenne muscular dystrophy, and this DMD you are able to diagnose by amniocentesis. One DMD is a progressive disease because it is a family hereditary disease and his cousin has got DMD. So it is our responsibility to give them the chance. There are 25 to 50% chances depend upon their genetic environment. So we have to give them the options of amniocentesis. So this is how we have to calculate the patient from high risk and low risk. Then we have to go for survey. You see, basically we have to survey globally, and in global survey we are able to watch number of baby, whether baby is live or not, what is the lie and position, where the placenta is located, and what is the subjective lighter. Here we are not measuring the amniotic fluid index, but we can see subjective lighter is little bit good. You can say single deepest pool at this juncture is good, placenta is anterior, baby is in breech position, but we cannot say in second trimester it is breech. We can say it is a variable presentation, spine looking fine, and we can see the subjective light. Then comes biometry. In biometry, we have to assign the gestational age we have to assess the growth just like biparietal diameter, head circumference, abdominal circumference and femur length. In first scan, you have to define the EDT and perfect LMD, and they have to make the CGA, that is composite gestational age. In subsequent scan, there might be change in EDT, but you don't have to change the EDT, and you have to see that patients are growth is okay or not. If you are doing ultrasound after 4 weeks or 8 weeks, your gestational rate should be around or 7 days or 14 days in the same gap that you have to done the previous ultrasound. So if they are not, then you have to think of intrauterine growth restriction. Now retardation one is removed. Don't write IUGR means intrauterine growth retardation. Retardation patient may believe that baby is not mentally well. So now worldwide the new documentary is FGR, fetal growth restriction. It is not IUGR means retardation, it is restriction. In biometry, we all know in first trimester you have to go for CRA, crown rump length. For that you have to measure from crown to the rump. You have to see the subjective liker. You can see the yolk sac. Yolk sac is the sign of first live embryo. In this patient you can say this is anterior, chorionic plate lies posterior. You can see this is white chorionic plate. Limbs buds are also seen, and you can measure knuckle thickness after 15 days in this baby, because here CRE is not around 45 mm. This is biparietal diameter. In biparietal diameter you have to see this arrow. Arrow is a thalamic plane. Here you can see two dots. This is known as K1 septum pellucidum. This is midline falx, and this is a BPD plane. Biparietal diameter is not the central diameter of head. It is the maximum transverse diameter of head. Then you have to go for abdominal circumference. In abdominal circumference, you have to see the hepatic portion of umbilical vein or entry of umbilical vein into the liver. On left side, you have to see the stomach. Posteriorly, you have to visualize the spine. There should be no heart and no kidney visualized in this plane, and you have to measure the abdominal circumference. Third one is femur length. From epiphysis to epiphysis, you have to measure the femur, and it is humble request. Always try to measure the femur which is near to probe. Now, with biometry, we are able to calculate the exact menstrual age from last menstrual period. We have to assess the composite gestational age from all 4 fetal parameters. Then we have to compare ultrasound age with the menstrual age. And as I said, at this juncture, you have to correct the EDD, or you have to accept the EDD which is given by the patient, and to decide the indication of serial scan. Whether you are suspecting IUGR, then you have to do scan frequently or after 1 week or 15 days. Then next step is you have to go for targeted scan. In targeted scan, you have to imagine baby from head to toe. Image fetal anatomy specific to the period of gestation. Suppose somebody says you have to see for lateral ventricle in 10 weeks of baby. It is not possible. Lateral ventricles are not formed. There is only dangling choroids. So all ventricles is filled with choroids. So at specific age of gestation, the anatomy varies. Okay, so you have to see the image the fetal specific anatomy for the period of gestation. Image for the specific risk factor. Suppose patient has got diabetes and you are doing 14 to 16 week scan. Just try to scan the heart, because we know that in diabetes mellitus there are chances of congenital heart disease is more. So you have to look for 4-chamber, RVOT, LVOT, 3-vessel tracheal view, and you have to see for the flow. Then there are a standard plane and section given for every structure, and this is known as rule of 3. So you have to examine baby from head to toe. Why you are examining baby from head to toe? Because here you want to prove the normality. You can say that baby look normal. So in every ultrasound report we are writing that no apparent congenital anomaly seen in present lying position. It may occur in different lying position, and you have to say that ultrasound cannot detect all congenital anomalies because there are so many evolving anomalies. In second trimester you cannot see, but in third trimester it may be visible. So you have to write these 2 sentences and you have to identify patient for the repeat scan. In head and spine, first you have to see head in three different planes. First plane is thalamic plane, in which you are watching the arrow. This arrow, there is midline falx and there is cavum septum pellucidum. In the same patient, you have to look for lateral ventricle. So it is known as ventricular plane. So first plane you can see there is ventricular, second is thalamic, and third you can see the cerebellum. So this is cerebellum. In this head, you don't see any banana, you don't see any lemon. Banana and lemon are very good in your eating dish. You don't want to see banana and lemon in head. If there is banana and lemon in head, then it says there is spina bifida. So you can see dry liver, dry head. The ventricle has got no fill with lichen. So it is known as dry head. And the cerebellum which becomes banana. The latest time given in cerebellar banana set is the crash sign. Just car is crashing towards the cerebellum, and cerebellum which is dumbbell shape had taken the shape of banana. So you can call it as a crash sign also. So no lemon, no banana. Sorry. Then you have to see for spine. See spine in three different planes. First one is sagittal plane. You can see two dots lying from right up to the sacrum to the cervical spine. Then see the spine in coronal plane. You can see three dots, two lamina propria and one body. Then you have to scan from neck to the sacrum. You have to see all three dots. If three dots are not there, sometimes there is disruption or sometimes there is little bit spina bifida which is covering over that. So you have to see these three dots from neck to the sacrum. Then you have to see spine in coronal section. So in coronal section you can see the spine very well. Now this is BPD, ventricular plane, thalamic plane, spine in sagittal section, spine in transverse section, and spine in coronal section. And let's see how it is looking video presentation. It is not difficult at all to measure all this. Always try to zoom the patient. Now you can see there is very good lichen. This is a ventricular plane. This is a thalamic plane. And just go below the thalamus, you are able to see beautiful cerebellum. Okay? Below the thalamus, there is cerebellum. Because thalamus and cerebellum both are lying in occipital lobe. Then look at the spine. Again, always try to use the zoom button. You can see this spine very well. You can see the spine from here to here. Now I am using the zoom button. See the spine. Which spine it is? Sagittal, coronal. It is a sagittal spine. You can see from neck to the sacrum. Then same spine you have to see for three dot. Okay, you can see three dot from here right up to the sacrum. Okay, you can see neck, ribs also. Then you have to see for the coronal spine. In coronal spine, just like a female, very good knitted chotla. What you can it is a hair weaving. You can see just like very good from neck to the sacrum. So you can very well say that this baby doesn't have spina bifida or spine is okay. There is no spinal ripprabism, no any skin deformity in the spine. Again see for all these three things, three dots. You can see without zoom also. You can see three dots. Then move this baby. You can see the sagittal spine. You can see the coronal spine. Once your eye is acquainted with the ultrasound machine, you are able to see all these three things. So three plane in head, transventricular, transcerebellar, transthalamic. Three plane in spine, sagittal, coronal, and transverse. In abdomen, you have to see three things. First thing, in abdomen and thorax. In thorax, you can see heart and two bilobed lung. You can see thymus also. So in abdominal section, you can see three things. Okay, stomach bubble, hepatic portion of umbilical vein, posteriorly there is spine. So this is perfect abdominal section. Below you can see two kidney just lying near to the spine. You can see there is no heteronephrosis, both kidney lying in the same plane, and you have to see the entry of umbilical cord into the abdomen. In early 10 to 11 week, you can see physiological herniation. So if you are able to diagnose umbilical, then that is gastritis, you can see over here, and this is hepatic portion. And this umbilical vein, you can see it is it is going around the umbilical bladder. So if suppose patient has got no life, you can measure the umbilical vessel at this level of urinary bladder, because here umbilical vein divides in two. Now you can see in this video, again see the zoom. You can see stomach bubble, posteriorly there is spine, anteriorly there is hepatic portion of umbilical vein, and you have to measure this abdominal circumference over here. Then see for entry of umbilical cord. The umbilical cord going inside. Sorry. Umbilical cord is going inside. No umbilical, no gastrochiasis, no anterior wall defect, no ventral defect. Then here you can see both the kidney. You can see kidney 1 or 2. This is one kidney. This is second kidney. You can measure the kidney also. This is kidney. Without zoom also you can see all these things: stomach bubble, spine, hepatic portion of vein. Here you can take abdominal circumference. Go little below, you can see both the kidneys. Go anteriorly, you can see the cord insertion. Then in next step, you have to see the limb and face. In upper limb, you have to see the humerus, radius ulna, and fingers. We are lucky that in 14 week of scan, baby has got open arms. After 20 weeks, baby will clenching the fist. So at 20 to 22 weeks, if you want to see the polydactyly, you can't see. So at 14 to 16 weeks scan, baby has opened your hand to see that they have got 4 finger and 1 thumb. No polydactyly. So you have to see humerus, radius ulna, and fingers. In lower limb, you have to see the femur, you have to see the tibia fibula, and we have to see the limb. And this limb usually lies at the 90 degree. You can see. So with this angle, you know that there is no talipus equinus varus. There is no deformity in the lower limb. Then in face, you have to see nose, upper lip, lower lip. If upper lip and lower lip both are looking good, you can say that this baby don't have cleft lip and cleft palate. Then you have to see 2 eyeball. You can see 2 eyeball. Okay, so here you can see 2 eyeball. See, 2 eyeballs are there, and in eyeballs you can able to see the lens. Okay, this is are the lens. And you can see nostrils, upper lip and lower lip. So in limb and face section, you have to see all these things. Now see the video. This video shows you the lower lip. You can see. First you are able to see the femur. Okay, this is femur, and again I am saying always measure the femur which is near to probe. Then always, usually baby lies in Krishna position. Always cross the leg. Then in leg you have to see there is angle maintained between the foot and tibia fibula. Now you zoom it. You can see this is femur. Again, this is second femur, and always try to see both the limbs. You have seen the patient with absent limb, that is because of the amniotic bend syndrome. So always try to look all 4 limbs, particularly 2 lower limbs with tibia fibula and both leg should move properly and they have the angulation maintained. So there should be no club foot, no talipus equinus, no talipus varus. You can maintain the anatomy and just give little bit thrust. Maybe we will move the limbs and maybe we will show that I am okay and I want to run out of from this uterus and come to you. You can see baby's limbs are moving. So you can see moving limbs. Then see for the face. You can see the face. Both hands lie upwards. You can see upper lip and lower lip very well. With zoom you are able to see the upper lip and lower lip. Chin is also very well visualized. You can see the two nostrils. This is only 14-week baby. We can see that we want to see how much time it will take. In last slide I will show you that this won't take more than 3 minutes of yours. You can see two eyeball with lens inside. Baby has opened their mouth to show you his tongue or her tongue. You can see spine. You can see baby's face. Baby is moving. So always try to visualize when baby is towards your side. Now see the upper limb. Upper limb, the bone which is near to heart is humerus. Remember, humerus and femur are look alike on ultrasound. So how you define whether there is humerus or there is femur? Femur never comes at the level of heart. So the bone which is near to heart is always humerus. Once you look at the humerus, go towards the side of humerus, you will see radius and ulna. Then you are able to see the fingers and you are able to see thumb and forefingers. Okay, here you have to visualize. So this is femur and then you have to visualize, or this I am measuring the humerus. After measurement of humerus, this is face. So these are the two upper limb. Baby has got two upper limb towards face. You can see these are upper limbs lying over here. Yes, you can see fingers. Yes, yes. Baby is saying hi to you. With zoom, you can see there are fingers, which is open one. This is again second bone. And remember, this bone is not humerus. This is femur. Okay? That's why I am locating the bone which is near to heart. Near to heart is always humerus. Femur never lies at the level of heart. This is radius and ulna. You can measure radius and ulna both. Okay, you can measure this is radius and ulna. And now baby is showing all his four fingers. You can see both the limbs, fingers are very well, no polydactyly. Baby says hi. You can see the baby thumb also here. You can see baby's thumb, baby say hi. Four fingers and thumb. So you have to see everything in upper limb, lower limb and face. Then comes reporting. This is rule of three. In head, you have to see falx, choroid plexus, brain parenchyma, ventricular system, cerebellum, cisterna magna. Cisterna magna you have to measure and cisterna magna is usually less than 10 mm. In thorax, we have to see cardiac situs. In cardiac situs, we have to, if you want to pass in fetal echocardiography, remember PASSS. First is position, size, symmetry and squeeze. Position, axis, size, symmetry and squeeze. That is the first pass. Second is three vessel view. Position, alignment and size. Pulmonary, aorta and suprarenal. You have to see all these things in fetal echocardiography. Once we will take fetal echocardiography presentation, we will do it in detail. Then you have to look for pleural cavity, fourth chamber, alveoli, and you have to see lungs. Usually we are not visualizing the lungs, but we have to see lungs. Sometimes we can see CCAD, or we can see the atelectasis in the lung, one lobe is missing, or we can see the cyst in lung. In abdomen, we have to see for abdominal situs with the stomach bubble on left side. We have to see the small bubble. We don't have to see the double bubble, that is duodenal atresia. You have to look for the peritoneal cavity. You have to look for the large bubble, that is usually we can see the peristalsis in the intestine, and these intestines are looking very good because it is studded with meconium. That is, no baby has not passed any stool. So it is studded with meconium, so you can able to see the small and large bowel. Because of PNP, PCPNDT, we don't want to see the genitalia, but in particular situation when you are suspecting pseudohermaphroditism or we are suspecting some sex leak disorder, we have to see the genitalia. And we have to see both the kidney. We have to see both the kidney in the baby. Then we have to see both the kidney, we have to see the urinary bladder, whether bladder is full or not. In bladder particularly we have to see for wound belly syndrome or posterior bar obstruction. In limbs we have to see upper limb right, upper limb left, upper limb right, humerus, radius ulnar fingers, lower limb, femur, tibia fibula, lower limb, and we have to see for the proximal, mid and distal segment of the limb also. So this is checklist for fetal imaging. Then we have to look for the fetal activity. Fetal activity comprises of flexion and extension of all limbs. If baby is moving very well, it means that baby is getting very good oxygen inside the uterus, from the uterine artery, from the arcuate artery, through the umbilical artery. Baby is getting very good oxygenation. So fetal activity ensures that baby is getting very good oxygenation. Fetal environment is comprising of placenta. In placenta, we have to see for the placental location. Any retroplacental clot is there or not. Previously, we are documenting placenta by grade 1, grade 2, grade 3 with calcification, without calcification. We have to see the cotyledon. New nomenclature came: mature, immature, and hypermature placenta. Then we have to see the placenta with Nitabuch layer. So there is a separate layer between the uterine wall and placenta. Devotion of this layer will make placenta accreta or placenta percreta. You have to see for this placenta is low lying or not, and placenta previa is there or not. Liquor is subjective. You can see for single depaste pool, and if we have to be specific, we have to go for amniotic fluid index, in which we have to divide the abdomen into the 4 parts, and in abdomen we have to see for the liquor, and this liquor is 4-part estimation of this. Liquor comprises of amniotic fluid index. Then in umbilical cord we have to see for 3 vessel cord. So this is AFI. We have to measure AFI only after 28 week of gestation. Normal amniotic fluid index is 8 to 20. 5 to 8 is borderline. Less than 5 is severe oligo. 20 to 24 is borderline poly, and more than 24 is poly. Here you can see this is polyhydroamnios, and in next picture you have to see this is oligohydroamnios, and this is polyhydroamnios. You can see subjectively you can identify that this is very big pool of liquor. Now you can see this liquor in this patient. You can see environment of liquor is very good. You can see baby is moving. Baby don't want to show his face, so baby is shying, having 2 limbs in front of the eye. You can see liquor subjectively is very good. Now we have to see the placenta. This placenta lies anteriorly. Very good differentiations in between the uterine body and placenta. Homogeneous placenta. No cyst, no indentation, no cotyledons has got deeper, because placenta is condensation of different cotyledons, and God is very kind to us. That's why He has given placenta with cotyledon. Some cotyledon has got infarction, and second cotyledon will take work of this placenta, so we don't deprive of any nutrition. So lastly, we have to go for reporting, and every reporting we have to give report after every reporting, and it should reflect the findings and interference from the each step. It should give clear, meaningful message, and always try to compare with previous scan. So first is history. Why you have to do the scan? This is indication of scan. Single, live, intrauterine, in different presentation. Do all biometries and values in targeted scan. All the organ image normal for this gestation period. Mention the organ not seen. Suppose in abdominal section you don't see stomach bubble. So write stomach bubble, not seen. Advice to look for stomach bubble after 15 days. You have to look for cardiac activity. Again I say, if you want to pass in cardiac examination, do pass, pass and pass. And this is in my YouTube channel, pass, pass, pass and pass in fetal echocardiography. C for fetal environment, that is placenta and liquor. And lastly, the summary with relevant findings you have to give. When examination complete? Obstetric examination never complete. We can't say baby report is normal. We have to say at this particular juncture, baby looks okay. There are evolving anomalies. So always write these two sentences in your ultrasound report. No apparent congenital anomaly seen in present lying position. Ultrasound cannot detect all anomalies. Then how patient knows that you have done good job? It is our custom that we are having a TV in front of the patients. Connection is going from ultrasound machine from this HD TV, and patient is watching his whole ultrasound in that TV screen, and we can give them the recordings. But nowadays with PCPNDT we are supposed to give only images. So no live recording is allowed to give to the patient, but we are giving 10, 15, 9 depends upon the good images we are able to capture. We are giving all the images in a HD glossy paper, and while we are performing examination, we are narrating that this is head, this is limb, this is eye, this is eyeball, this is heart. So you have to see that patient should be satisfied and patient can see that you have done your good job. What is the liability if pregnancy outcome is unsatisfactory? We are not God. We don't want to prove ourselves God. God has given us the responsibility to serve the humanity, and we have to serve the humanity with best of our efforts. So in carry home message, the final 3 things. Again step of 3. How we are able to give good targeted scan. For that we have to require good equipment, committed sonologists and USG friendly fitters. What I mean to say USG friendly fitters? You want to do the fetal cardiac examination and spine is anterior. Believe me, you are not able to see the heart properly. You have to see the heart from the lateral scan. Don't do this type of juggling. Tell patient to come after 15 minutes. Have a one coffee or climb them to stairs for 1 or 2 times. When baby change or move from spine anterior to spine posterior, do the fetal heart scan. So baby should be friendly. So following this rule, ensure that there is no major anomaly will be missed. So this is the scan. You can see this is a live scan. Now I am demonstrating in live scan. You can see there is BPD plane, thalamic plane, cerebellum. Then we are watching the spine. You can see spine in sagittal section, and you can see spine very well. Then you are able to see the upper limb. Just see the things which comes to you. Okay, this is spine. I am going always stepwise. Arrow always point towards spine. Okay, you can see 3 dot, 2 lamina propria and 1 body. Here I am looking at the spine. I am not looking at the heart. I am just looking at the spine. Okay, then spine goes right up to the sacrum. Then next step will be watching the lower limb. You can see femur. You can see tibia fibula. You can see the lower limb which is lying over there. Then you are able to see this both lower limb very well. Okay, you can see this is face. We are able to visualize 2 eyeballs. Very good. We are able to see the, here we are watching only lower limb. So no think about the face. Then now we are taking the face, 2 eyeball, nose, upper lip, lower lip, very well seen. Subjective liquor is very good. We are able to see 2 eyeballs and upper lip, lower lip. Okay, and then here the hand comes. You can see the upper lip. Luckily there is no clenching of fists. You can see 4 fingers. Here you can see the thumb. This is second thumb and 4 fingers. Radius ulna and femur. Why femur? There is humerus. The bone which is lying near to heart is humerus. Here you can see the stomach bubble. Umbilical cord is very well visualized. Stomach bubble is seen, heart is seen. Both upper limb very well seen, so there is no anomaly in the limb. Both limbs look okay. Then we are able to concentrate on the stomach. Here the stomach bubble, this is heart, and see the baby. If this baby is ultrasound friendly because spine is posterior, we are able to see heart very well. So if you have to pass in heart, again the same principle, position, axis, size, symmetry, squeeze. Here we are watching the femur. So this anomaly scan is not difficult. Imagine things in your mind. See 3 different planes in all the given anatomical plane and see the normality for the fetus. So this is normal ultrasound. Thank you very much. And at this juncture, I would like to thank my teacher, Professor S. Suresh, for teaching us and giving us the principle of rule of three.